Let me get a little bit of history of myself. I'm Shawn from Moses Lake Professional Pharmacy. And my wife and I, Janet, are both pharmacists, and we've had our pharmacy since 1998. So for 22 years now, we've been helping people with hormone replacement. We specialize in compounding, so customizing hormone replacement for specific individuals. That's 90% of what we do in our practice. So we really focus on that. We have a passion for it. We help patients all over the nation with hormone replacement, and we help doctors with their patients. And it's very rewarding for us. We love doing it. And it's something that we really focus on. So we love working with doctors like Dr. Bahnmiller. Dr. Bahnmiller, you want to go ahead and introduce yourself a little bit?
Sure. I'm Dr. Bahnmiller. I'm an OBGYN down in the Tricities area. I've been practicing since 2002. I took special interest in doing women's sexual health, which involves a lot of hormones, which works with an organization called ISWISH, which is International Society for Study of Women's Sexual Health, because I've seen that that's kind of like a neglected area of women's health care. It's kind of like the new Vogue thing, but we've been doing for quite a while, just trying to help complement and balance that out. I also work a lot with the NAMS criteria for hormones, but a lot of times too, it's kind of our take is we got to do what's right for a patient, not just what's straight FDA approved. And so that's kind of where I come from.
Right. And what's the name of your practice, Dr. Bahnmiller?
What's that?
What's the name of your practice?
Columbia Shores OBGYN, and also Tri-City Sexual Health.
Awesome. All right. Well, let's go ahead and get started. So menopause and hormones. I think one of the ways to start out is just get some objectives. We're actually define menopause, and I'm going to actually go to the expert, Dr. Bahnmiller, when we do define menopause, and learn what hormones need to be replaced. I think some people might be surprised at that. Traditionally in pharmacy school and medical school, I don't think we learn all the hormones that need to be replaced during menopause. We just maybe learn, maybe one of them, like estrogen. So that also just goes into the idea that, the ovaries do produce more than just estrogen. And what are the long-term consequences of lack of hormones? There's many disease states that we prescribe drugs for that actually, if your hormones are balanced, you really don't need a lot of those drugs. We'll get into that too. Dr. Bahnmiller really has a passion for talking about estrogen and cancer, and just learn really that all hormones are not equal. The hormone's a very broad term, so we need to define that. Go ahead, next slide. Menopause. So here's a slide basically, and basically the and I want you to comment after I do, Dr. Bahnmiller, is the strictest definition is at cessation of cycles after 1 year. If you haven't cycled for 1 year, then they call it menopause, and we name it menopause. And that usually happens in 40s or 50s. I will say this though, there's many women that they won't cycle for 1 or 2 years, and then all of a sudden they cycle again. So there's not really that's the black and white definition, but it's not always that simple. Can you comment on how you define menopause, Dr. Bahnmiller?
Well, I mean, that's a classic definition. And to be, in all fairness, we got to have some kind of guideline to kind of stick with, as far as saying, like you said, no cessation of menses for a year. There's some that, okay, they won't have menses for a couple of years, and then they start cycling. Those I get concerned about, just because you want to make sure, okay, are they still cycling? Do they still have hormones, or is there something going on? And especially in that age range, when you haven't had bleeding for a while, then you have bleeding. First thing I think about, okay, let's make sure things are okay, that there's nothing abnormal going on with the uterus, like endometrial cancer. Once you kind of set a baseline, maybe get some baseline labs, and then also make sure that there's no endometrial cancer, which is a simple test. Then you can say, okay, now how do we make sure that, okay, are these cycles normal, or are they something that we need to treat them hormonally? And a lot of these women too, that's where they kind of get left out. First of all, they don't get, I'd say, adequately evaluated to make sure that there's nothing bad going on. Second of all, when everything's okay, a lot of times they're like, oh, just kind of tough it out and don't go on hormones. And I think that's kind of detriment to her health too. Whereas those cycles may be indicating, okay, she's low in estrogen or something else is going on that we need to supplement.
And let's go ahead and define too the difference between surgical menopause and natural menopause. Can you go ahead and talk a little bit about that, Dr. Bahnmiller?
So natural menopause is where the ovaries decline in functioning to the point where they're not producing the hormones. Primarily, the one that we always hear about or think about is estrogen, but then you also have testosterone, progesterone. There's hormones, obviously, we don't know about or understand at this point, but those are going to be our primary ones. The ones that people focus on is estrogen, because most women will come in with a primary complaint of hot flushes, not sleeping well, weight changes. So that's usually a gradual process. You tend to see women kind of gradually working into those symptoms and transitioning through, whereas surgical menopause, when for some reason we need to remove the ovaries during surgery, and that puts them in much more abrupt menopause, where their symptoms are typically a lot more compounded, just because they go from a certain level that they're at. Normally it's kind of almost a normal level to no hormones. Sometimes it's at a point where they're going to go into menopause, but still there's a different abruptness. The importance of the kind of understanding the two is that when they go into natural menopause, we're kind of seeing, okay, when and how do we supplement? Whereas when they go into surgical menopause, it's imperative to supplement them right away. Otherwise, they're going to have difficulty transitioning through the surgery, or also just transitioning as far as their health, as far as sleep and general well-being. And then you got to kind of, if you don't, then you got to kind of get to the point where you unwind it, and that, I think that's harder.
Yeah, and many times surgical menopause happens when they're younger too. So, the underlying effects of no hormones, less bone density, all that it can be a bigger detriment because it's longer term. Correct.
Right. And too, even if that's where I think we need to be a little more aggressive on supplementing, because if you look at those women, unfortunately we can't replace what nature's made, but the more aggressive we are, the more we can actually get them to the point where we're going to improve their cardiac health, their bone health, their bowel health, all sorts of aspects, and their sexual health, all sorts of aspects of their health, to at least giving them the best we can. If we kind of just let it go, studies over and over have shown that there's a significant drop in their overall health and lifespan.
Yeah, and we'll get into that a little more in detail a little bit later in the slides. Can you mention too, because I think there's some confusion about, a hysterectomy versus a complete hysterectomy, and how that affects your hormones. Can you define the difference, Dr. Bahnmiller?
So yeah, there's confusion when we talk, and a lot of times we assume people understand our terminology versus language. A lot of people say, well, I had a complete hysterectomy. And when you come from the lay public, typically that means they had their ovaries taken out. Well, coming from medical side, a complete hysterectomy is taking the uterus and cervix and tubes. It has nothing to do with ovaries, an oophorectomy. So when you read the records, unless it indicates removal of ovaries, they still have their ovaries. If you took out, the uterus and ovaries, then we usually call it a total hysterectomy with bilateral self-paying oophorectomy, taking out both tubes and ovaries with uterus. The difference is that when you take out the uterus, you still retain some of the ovarian function. Now, the reason I say some is because we'd like to say you keep all your hormones. The ovaries do diminish in a certain amount of function because we disrupt some of the collateral blood flow to the ovaries. So even those women, you want to see, okay, are they having symptoms? How are the hormones doing? That to the best way we can evaluate, is it affecting aspects of their life and their health? When we take out the uterus plus ovaries, then that's when you see a drastic reduction in hormones. So both sides, you need to kind of look at hormones, because they are affected on both aspects, even if you leave the ovaries there. But really, when we take them out and do taking out both our ovaries, then you definitely are diminishing her hormones.
I love it. Thank you for clearing that up. All right, we'll go on the next slide. And perimenopause, we don't, this is about menopause, but we don't want to spend a lot of time on this slide. But basically, perimenopause is the time before menopause. Women are still cycling. Sometimes their cycles can be irregular.
So the thing I want to comment on, I think is very important is that this is a time when women will still be having cycles. Typically, they're spacing apart. Now they may get closer together, but this is when you want to be very vigilant, making sure, okay, there's no endometrial cancer first. But the point you made about the decreased progesterone, I think this is where a lot of women get missed, is that they're like, okay, you're just going through perimenopause. Well, this is where I think we need to actually utilize more supplementation and progesterone. Most providers, what they'll do is, okay, let's straighten out your hormones and put them on a straight birth control pill. The reason I have a problem with that, you're really going to throw their hormones for a loop. You're actually putting them in early menopause, and you're not doing their health any benefit. So this is where I tend to prefer to cycle with a natural progesterone the last couple of weeks of their cycle, just to keep them on a normal cycle, keep from bleeding heavy, and also help them kind of have a more natural hormonal transition. Then when their ovaries stop functioning, they don't have they go into menopause. That's when I like to supplement back to estrogen with the progesterone.
So here's a slide. It's kind of just to add a little bit of humor to it. But when you think about this, there's a horse, and we're trying to give a horse human estrogen. I like to comment on this slide because I think it's very important that our patients people know where their source of hormones are and comes from. And a lot of people don't know where Premarin comes from. And Premarin stands for pregnant mare's urine. It is isolated from horse urine with pregnant mares that it's high in estrogen. So they isolate it from horse urine. It's standardized to an estradiol ratio. So there is estradiol in there. There's estrone in there, which is natural and bioidentical to humans, but there's other estrogens in there that we don't know of. And I honestly believe that prescribing Premarin nowadays with, we have a alternative of estradiol, estriol, we have alternatives of bioidentical hormones. I think prescribing Premarin nowadays is kind of analogous to prescribing beef and pork insulin. We don't prescribe beef and pork insulin anymore for humans because we have human insulin. So I think that's what it's like prescribing Premarin. And Premarin used to be, especially when it was the only estrogen out there, I think that it was a great option. But now since we have other alternatives, I'm just not a big fan of Premarin for multiple reasons. Dr. Bahnmiller, do you have any comments on that?
I pretty much agree with what you're saying. I don't like the fact that when we take products from, I'm not just saying like animals, but when we take products that have more or different than what we know that's in there, then it gets a little concerning. It's like, okay, what are we replacing back?
Right.
And so even when you say natural, I mean, somebody could argue horse urine is natural. I think we got to kind of complement what the body is missing and utilize it, just like we do with thyroid medications, like you said, or insulins. We don't want to cause the body to do things as far as having autoimmune reaction against it or cause things that harm that we don't know about.
Absolutely. So we'll hit on the biosynthesis of hormones a little bit. We already talked about the ovaries because that's where a lot of the hormones we're talking about today are produced that we replace. But you do have the adrenal glands, which is right above the kidneys, that produce other hormones. And let's not forget about thyroid. So I think one thing that's important about this slide is that hormones are that's a very broad term. So when we hear about hormones, and I'm guilty of it, and I'll say it in this presentation today, when I talk about hormones, I still use it in a very broad term. But let's realize when we say hormones, that's a very broad term. Insulin, for instance, is a hormone. So, but we could talk about thyroid hormone, we could talk about adrenal hormones, we could talk about ovarian hormones. So I think it's important to know that all hormones are not created equal, and it's important to know that which ones cause what kind of side effects and which one can cause problems. Because I know in the medical world, like for instance, when somebody gets a diagnosis of breast cancer, some doctors will say, oh, well, you need to go off all your hormones. Well, that's a very broad term when you say you need to go off all your hormones because you had breast cancer. What about thyroid hormone? So do you have any comment there, Dr. Bahnmiller?
Well, I think breast cancer kind of gets is one of those things that drives us off of fear, because that's a big concern with women, which is understandable. But when you look at it, we have from the range of women just not wanting to go on any hormones because of studies saying, oh, that's going to cause breast cancer. Well, if you really look at the studies altogether, estrogen and progesterone haven't been shown to increase risk of breast cancer statistically. And if you look at all the studies, especially if you take estrogen alone, there may be even a decrease. And it depends on which hormones were supplemented. Then you look at women that from family history, if you have a family history of breast cancer, or if you have like a gene mutation, people say, well, I shouldn't be on hormones. No, you should still be on hormones, because studies over and over always showed that there's an improvement in your overall health, morbidity, your long-term, general health, and decreasing your mortality being on the hormones. Now, when you get breast cancer, that's where it needs to be defined more, and that's where the oncologist, they need to run and say, okay, is this estrogen, progesterone, testosterone sensitive? And if it is, then it's like, yeah, we don't want to feed into it. But ones that don't have that positivity, there's no reason not to have them on hormones, because you're still negatively impacting their life if you don't.
For sure.
I mean, you got to look at it from a patient to patient. And unfortunately, we kind of lump everything in and say, and then we run off, oh, that's going to cause problems, let's just not do it. Well, no, you got to really look at the patient, look at the study, say, what do we know that helps and hurts?
Right. Exactly. Perfect. Thank you for that. Next slide. Let's see. Do you go backwards? We already talked about that. So here's, when we speak about hormones just in general, here's a list of some hormones, and they all do different things. So it's important to know that not all of them are created equal. Let's go ahead and go to the next slide. So
a quick comment on that.
No, go ahead, please.
You listed estrogens. Now, when we talked about surgical menopause or even loss of ovarian function, the main one we lose is estradiol, which is our most potent estrogen. And that's why you'll see that estradiol and then estriol is the next one. Those are the ones that you kind of see being supplemented the most. And the reason is because the ovary produces the most of them. Now our adrenals and then our body fat makes the other estrogens. So women that have their ovaries taken out or in menopause do make a certain amount of estrogen. That's where it's imperative to kind of, treat them case by case. And then when you look down the list, testosterone, unfortunately, women get the short end of the stick when being treated with testosterone. I mean, obviously, men, you're going to notice significant more changes and things that directly affect that men are going to complain about. But you really have to tease out of women to say, okay, is there, what's the importance of supplementing with testosterone? And that's very important too. And that you got to balance that with estrogen. And that's what I think a lot of people don't, we're not trained on, we're not taught about. And unfortunately, women aren't getting the treatment. That's where you're going to see weight gain problems. You're going to see just muscle, energy, overall skin health. The testosterone has significant impact on women, and they just don't get the fair side of it all.
Absolutely. And we'll get a little bit more into that when we talk about testosterone. So if you notice on that last slide, and Dr. Bahnmiller commented on it, there is more than one estrogen. And you'll hear it when I present on hormones. You'll hear me lump all estrogens into one category sometimes. And traditionally, when I say that, or generally when I say that, I really mean estradiol most of the time. That's not always the case. So it's important to know that there are 3 different estrogens in a woman's body: estrone, estradiol, estriol, and it's important to know that they all do have a little bit different functions. So when we talk about estradiol, normal growth and development of female sex organs, secondary sex characteristics, proliferation and growth of specific cells in the body. When I think about that, I think about uterine tissue. It causes the endometrium to thicken. It protects against bone loss by decreasing osteoclast function. It does, contrary to what you may have heard, estrogen does not cause heart attacks. In fact, estrogen has a very positive effect on your cholesterol. It raises HDL. It works great. When I say anti-aging, I know it's a pretty broad term, but collagen in your skin helps to stimulate collagen in your skin, so helps to keep your skin healthy. So, Dr. Bahnmiller, you want to comment at all about importance of estrogen?
The one thing is the fear as far as causing heart attack, and I think a lot of that came out of the Women's Health Initiative. The issue is that it's how the estrogen's applied. Now, in that study, they took women that were like 13 to 15 years past menopause, so all of us are going to have heart disease. And if you take estrogen orally, the liver produces more clotting factors. It's not causing you to have arteriosclerosis. It's not causing problems like that. But what it does, it makes you more likely to clot, which is the intent of the liver with working with estrogen. Now, if you take it transdermally, you bypass that. And so that's why my preference is topical estrogen, because we're bypassing the liver. We're not messing with, okay, in women, you'll see it's in the package insert in most estrogens, it says that contraindicated women with heart disease, women with clotting disorders,
Right.
DVT, stuff like that. Well, if you go transdermally, you bypass that. You could still apply estrogen even when they have that history, but that's when you want to limit them from taking the oral estrogen.
Yeah, correct. And let's talk a little bit about estriol. Estriol is important. It's, I believe, it's less potent than estradiol. It won't work for like vasomotor symptoms necessarily. The nice thing about estriol is it binds the estrogen receptor weakly, so it can block some of the effects that estradiol have, like proliferation of tissue. So it won't cause overstimulation of breast tissue and uterine tissue. And it's great. It's very specific for vaginal tissue. It can work great for vaginal tissue, very specific for that. So I love estriol when it comes to any kind of vaginal problems. Dr. Bahnmiller, I'd love your comments on this slide.
I agree with you completely on that. I think it's a great product for vaginal estrogen, because then we kind of avoid the fact as far as overproliferation of endometrium, which is where you'll worry about it. When we use a vaginal estrogen, the amounts we get in the blood levels are insignificant as far as affecting negatively on the body. So if patients will tolerate and will go for it, I think vaginal estrogens for general urinary symptoms like vaginal dryness, stuff like that, are amazing. And estriol, I think estriol is going to be, in my opinion, the better product.
Yeah, awesome. All right, let's go to the next slide. So obviously, we talked a little bit about some of the symptoms that happen during menopause, like hot flashes and vaginal dryness, things like that. So those are some of the benefits of estrogen therapy. I already talked about the lipid profile, how estradiol increases HDL. Osteoporosis, we always worry about breast cancer in women, but one of the most debilitating diseases in women is osteoporosis. And, estrogen is one way to keep the bones healthy, along with testosterone and progesterone. So memory disorders, it's been shown many times that estrogen can help prevent dementia. And of course, maintenance of skin health because of the collagen that estrogen helps stimulate. Menopausal symptoms, I listed hot flashes first because that's, I think, one of the number one reasons that women, seek hormone replacement. But the list goes on. I don't need to read it. It's in the presentation. But hot flashes, vaginal dryness, and decreased libido are very, very important. What do you see when women are seeking hormone replacement? What do you see as some of the major symptoms, Dr. Bahnmiller?
Well, the first thing I comment on, it's the hot flushes, but it's also cold flashes too. So women will complain, "Oh, I'm always feeling like I'm really cold or hot." Most women, you'll hear hot flushes. The biggest thing that I think we kind of dismiss a lot of times is those hot flushes. Women will come in a lot of times saying they just have no energy. They feel like they go to bed, they get 8 hours sleep, but they don't feel like they sleep well. One of the important things that estrogen does is when you're sleeping, it helps with thermal regulation. So women will actually, say, "Well, I get 8 hours, but I don't feel well rested." That's because what happens is that the estrogen causes that temperature in their thermoregulatory part of the brain to set off, and that disrupts the sleep. So they'll just be in stage 1 or 2 sleep. They'll be sleeping, but they won't get stage 3 and 4, which is our deep sleep. And they may even get REM sleep, but it's the 3 and 4 that we need to be well rested to have energy for the next day. And what happens is that temperature changes just age that they may not wake up and throw off the sheets or be sweating, but it's waking their brain up. And they actually did a study where they took a bunch of college age guys, and they aroused them enough to keep them in stage 1 or 2. And they realized that their functioning the next day was worse than that of somebody that's legally intoxicated. So it has a significant impact. And when women think, "Oh, my memory's getting terrible, I'm just getting older, I just have no energy," think about that and ask them, "Okay, do you feel like you're rested in the morning?" You got to worry about things like sleep apnea, but one of the primary reasons for not sleeping well is because your estrogen is starting to decline.
Yeah, and sleep is so important. If we don't have good sleep, nothing gets
Forget
better.
it.
I mean, yeah, right. Forget it. So, all right, go ahead and go to the next slide. So we're just going to talk a little bit about the dosing, just really quick. So bi meaning 2-est estrogen, combination of estradiol, estriol. There's a lot of different formulations for this, and this is just kind of a very broad as when it comes to dosing, and Dr. Bahnmiller can attest to this. And I know Dr. Bahnmiller talked about oral estrogen and clotting. It still is an option because some women do not want to use topical creams. And so there's some dosing there with both the estrogens in there. I'm a big believer, just like Dr. Bahnmiller said, I'm a big believer in vaginal estrogen, and not just for local effects, but it is great for local effects, but also it is absorbed systemically. And we know that vaginal absorption, if you give the right dose, is the vaginal tissue is a great place to absorb drugs because it's a mucous membrane. It bypasses first pass effect, and so you can get good levels. Now, some of the reasons why you don't get good levels with some of the estrogen vaginal creams that are used for local effects is really just because of dosing. When you look at like estrace or estradiol vaginal cream, it's 0.1 milligram of estradiol. And locally, it works for local stuff like, urinary incontinence and to prevent UTIs and, atrophic vaginitis. But when you look at it systemically, you need a 1 milligram dose of estrogen, or of estradiol to work for systemic effects. So that's one of the reasons why a lot of times oncologists will say, well, even though you've had breast cancer, it's safe for you to have estrogen vaginal cream, because it's not necessarily because estrogen vaginal cream is not absorbed. It's not because estrogen is not absorbed vaginally. It's mostly because of dosing. So that's something that's very important to clarify. Dr. Bahnmiller, do you have any comments on that?
But and I agree. I think there's some women that are much more comfortable with a pill. I would just caution if you're starting it several years after they're going to menopause, because then you don't know what their cardiac health is as far as how much arterial grows. But the vaginal, I love vaginal for application. Now, always get women to apply things vaginally. A lot of women won't, but if they will, I think then you cover both areas. You cover the general symptoms and you cover their serum hormone. So if it's me, I would say that's my first choice. Now, getting everybody to do it, and I'd say a lot of women won't do it, but the ones that do, I think, are much happier.
Yeah, I agree with you 100%.
And it works so much better vaginally, because if you go the other way, then you have to do two different sources. You have to do transdermally or orally and vaginally.
Right, exactly. If they're having vaginal symptoms, absolutely. Yeah. So progesterone, I actually did a presentation. I've done a few presentations on progesterone, and I think progesterone, Dr. Bahnmiller alluded to it earlier, I think progesterone is so underutilized, and not just in perimenopause, but in postmenopause. It was actually the first sex hormone that we isolated and kind of studied a little bit. I think it was like 1937. I think one thing that I want to clarify is if you don't have a uterus, which is Dr. Bahnmiller talked about hysterectomies and such. If you don't have a uterus, you don't need progesterone. And that to me just doesn't make any sense. And it's not rational, because there is progesterone in our brain, in our skin, in all tissues in the body. So to think that just because you don't have a uterus and that progesterone only works in the uterus is just a misnomer. And that is very, very important that when you balance hormones, that you understand that. It is produced in the ovaries. It's secreted by the corpus luteum during pregnancy. I like to define what progesterone really means. Let's go back to our Latin, progesterone. So pro meaning for or support, and gesterone, gestation. So it supports gestation. And it acts in the uterus, the breast, brain. I talked about that. Kidneys, bone. It actually works with estradiol. It helps build new bone. It stimulates osteoblasts to build new bone, whereas estradiol actually decreases bone loss. Let's go ahead and go to the next slide.
Can I make a quick comment there?
Yes, and we're going to still talk about progesterone. Please make a comment, Dr. Bahnmiller.
Keep going, and I'll wait for you.
Okay, so here's what I like to say about progesterone is that, so it's for gestation. It helps support gestation. Many women that have a hard time, that if their cycles are irregular, a lot of times it's progesterone. Many women that have a hard time staying pregnant, miscarriages, a lot of times it's progesterone. I've seen women that have spent thousands and thousands of dollars on fertility treatments, and the doctor never checked their progesterone. I think progesterone is the most important hormone when it comes to that. And let's realize that not all hormones are created equal. So if you look at the structure of progesterone, remember we're looking at this in 2D, but these are actually 3D molecules, and how they interact in the body is more 3D. So small changes in the molecule can make huge changes systemically. Let's go to the next slide. So if you look at progesterone and medroxyprogesterone acetate, they're close in structure. Let's go to the next one. They're close in structure, but realize that, small changes in structure can have huge implications in the body. And I think this is one of the most important slides of this presentation. And this is one thing that I teach pharmacy students when I talk to doctors, when I talk to patients. If they can understand this, they will know more than most pharmacists and many doctors about hormone replacement. Is that progestins do not equal progesterone. So if you looked at that one slide where it talked about medroxyprogesterone acetate, it was produced to try to mimic progesterone, because after Premarin came out in 1940s, 10 years post, there was an increased incidence of uterine cancer. We shouldn't really be that surprised, because estrogen, we talked about, stimulates tissue. It makes uterine tissue proliferate. So it will thicken the endometrium, make tissue proliferate. Progesterone decreases that proliferation, and that's why they're made to work together. Wyatt Theris knew that after Premarin came out, but progesterone was a natural hormone. They couldn't really patent it, so they came up with medroxyprogesterone acetate, and to mimic progesterone, and it does somewhat in the uterine tissue, but it doesn't mimic in the breast tissue. It doesn't mimic it in the bones, and the cardiac profile doesn't mimic it. And when you look at a lot of the studies when they say estradiol, WHI study, which the Women's Health Initiative, which Dr. Bahnmiller mentioned earlier, part of that trial had Premarin and medroxyprogesterone acetate. And if you look at a lot of studies, they will erroneously put in medroxyprogesterone acetate as progesterone, and they are completely different animals. And here's the comparison I like to make. What does progesterone mean? Progesterone, support gestation. What do we use? And we use progesterone for fertility. We can use vaginal suppositories to help promote progesterone to help a woman get pregnant and to stay pregnant. What do we use medroxyprogesterone acetate for? What do we use Depo-Provera for? We use it for birth control. And that's usually when the bingo light comes on with most people. It's like, okay, wait a minute. Yeah, these hormones are close, but they're way different in the body. So that's the comparison I like to use. I have a big passion for progesterone. I think it's very underutilized. Dr. Bahnmiller, you've got some comments yourself on progesterone.
I totally agree. Progesterone, I think, is the least understood and under-taught hormone and underappreciated. One of the things I like your distinction between progestin and progesterone. This is what I always tell students that come through that work with me, is like progestins, are synthetic and they're more androgenic or more male-like. What that does is that then pushes, those then can get aromatized. Those can have negative effects on the body that natural progesterone doesn't. And that's why, when you look at birth control, I wish they're starting to, but I wish more and more of the medication, the birth control would have natural progesterone, not progestins, because we're affecting women's mental function, their whole neural behavior. We're affecting their body, their cardiac health. We're affecting their breast health in a negative impact. And we're actually putting them into like a menopause, I'd say almost as bad, if not worse, than a surgical menopause by putting them on birth control pills the way and it's primarily because of the progesterone. It is to a certain degree the estrogen, but that's a big part. And then if you look at as far as supplementing the natural progesterone, it's a little trickier. And the reason the companies don't want to do it is it costs a little more to make it. And also it's harder to, put it into oral pill. In order to absorb orally, we need micronized progesterone because progesterone molecule is too big orally. So you either have to do micronized or you have to do a transdermally to get it into the system in significant amounts. But I really like natural progesterone. The other part too in medical school, it's kind of like the only thing that they teach us is, oh, if you have a uterus, you give them estrogen, you have to give them progesterone. Otherwise, that's it. We're
Right.
starting to appreciate more in pregnancy, for helping with it, prolonging a pregnancy, but it's still not appreciated. One of the other factors is it's hard to measure. So as far as, it varies a lot in the body. So to get an accurate number is not as easy as like estrogen or testosterone. But really, I think it's almost imperative anytime we supplement estrogen and any hormones, we should always add progesterone because I think it only complements estrogen.
Yeah, I'm with you 100%. I don't think any woman should be on long-term systemic estrogen without progesterone. Our bodies make it together. I think it should be given together.
Mm-hmm.
So some of the uses of progesterone, PMS, like early perimenopause too. A lot of times anytime, I like to say it like this, anytime there is a cycling issue, like PMS or headaches that are followed by the cycle, anytime there's issues like that, think progesterone. Endometriosis. Why does it work for endometriosis? And Dr. Bahnmiller can comment on this. Well, I had a physician's assistant one time give this analogy. Think of estradiol as fertilizer of the lawn. So let's think of the uterus like the lawn. Estradiol is like fertilizer and makes the lawn grow. Progesterone is like the lawn mower, and so it thins the endometrium, preparing it for pregnancy. And with endometriosis, a lot of times there's just too much estrogen, not enough progesterone to help thin that endometrium. And that's the same thing with fibrocystic breast. Too much estradiol, proliferation of that tissue in the breast will cause fibrocystic breast. Many times, those can go away with just giving progesterone. And that's kind of the same with uterine fibroids. Also, anytime there's a cycling issue, progesterone, PCOS, that could be a whole presentation on itself. But that's many times is lack of progesterone, and of course, there's usually thyroid and weight issues also. Dr. Bahnmiller, what kind of comments do you have on that slide?
So one of the big things that I think is underappreciated is your top one there, PMS, or what's called PMDD, which is 2 weeks before somebody starts their cycle. They have significant symptoms, and that's usually you'll see naturally the progesterone drops, but typically in those women you'll see a higher drop than normal, and so then they get more symptoms as far as moodiness, depression, anxiety. That's where I think progesterone supplementation has a real benefit, is that 2 weeks before, so after ovulation and then up until their cycle, it does really well. That I think we're kind of a little bit, we could use a little bit more supplementing progesterone. As far as kind of the stimulating the lawn to grow and lawnmower, that's kind of a fun little analogy. What I like to think about estrogen, if left alone, it's made to make tissue grow. It makes the endometrium grow, it makes the breast tissue proliferate, stuff like that. And in our body, if we have unregulated growth, then we eventually develop cancer because things just kind of become disordered. Well, progesterone balances that out. And so progesterone is a thing that's kind of putting, the brakes on. And so that way the growth isn't erratic. It's kind of like a nice uniform growth. Otherwise, that's where you start to see irregular bleeding problems, or like you said, fibrocystic breast. And we don't really completely understand endometriosis, but it may be that lack of progesterone or the utilization of synthetic progesterones that were creating this. So
Exactly.
All these you can spend forever talking about.
Yeah, I love it. I love having you on this presentation, Dr. Bahnmiller. You're truly an expert in this field, and thank you for your wisdom and information you're giving us.
I appreciate being here. One thing that polycystic you just mentioned, one quick thing to think about. I personally feel like we create a lot of polycystic with birth control, because and I was trained with the infertility doc. He said there's one thing to remember: PCOS spelled backwards is OCPs, which is oral contraceptive pills. That's how they're taught to treat. Well, the problem comes in again, the progesterone. and it's an androgenic. And what is a big problem with PCOS is that it's a hyperandrogenic state, throwing these women into a metabolism. And we blame the poor ovaries. The ovaries are just a side victim, but really it's because we're messing with their androgens and their progesterone, and that's where we're getting in trouble. And that
Right,
I believe we're creating more of a problem.
I'm with you, and I know the longer I focus on hormone replacement, and I'm speaking for my wife too, the more we just realize the detriment of birth control pills, and it seems like you kind of have the same opinion, Dr. Bahnmiller. And I think there's a place for them. There is no doubt in my mind, but I think the faster you can get off of them, the better, because the long-term consequences. And here's with PCOS, just not to go on too much of a side tangent, but with PCOS, one of the problems is the patient's not cycling already. They're not having regular cycles. So in my opinion, you need to fix that problem. Get the patient cycling regularly, and then that can fix a lot of those problems.
And that's where, if we use natural progesterone, I think you're going to have a better time keeping them healthier, because honestly, this is a mindset that we're taught. Is like, okay, a PCOS, the big concern is developing endometrial cancer, and having abnormal cycles driving you crazy. And so if we use natural progesterone and get them cycling, I think they do so much better. And they stay so much healthier.
Yeah. And speaking of natural progesterone, when you look at the side effects, if it's dosed appropriately, you can get slight to moderate drowsiness. That's mostly with the oral form. It's not to say that the topical form won't cause that, but when you take it orally, it's metabolized in the liver to have allopregnanolone. So we're going to keep going as we get Dr. Bahnmiller back on the line. So we already talked a little bit about progesterone. The nice thing is that it's the side effect profile is very minimal if dosed appropriately. And look at the side effect profile of synthetic progestins like medroxyprogesterone acetate. Look at some of the things that it does cause: thrombosis. I like to talk about thrombosis that the synthetic progestins cause, because that's one of the issues that causes a heart attack, whereas progesterone doesn't necessarily cause that. So there's just a side effect profile of medroxyprogesterone acetate, and that is, doesn't come up with progesterone. So let's go ahead and go to the next slide so we can keep going through here. Function of progesterone. I think one of the important things about this slide is that it counteracts a lot of the issues with progesterone. Dr. Bahnmiller already kind of mentioned that when it comes to estrogen proliferating tissue, progesterone stopping proliferation. We talked a lot about progesterone, so I'm just going to move on through these so we can go. We talked about progesterone osteoporosis already.
I think one of the quick things there, Shawn, the last one, decreased cramping. I think, and two, a lot of times they're a younger population. If they're not on birth control, one of the nice things natural progesterone does is decreasing the cramping during the cycle, and also decreases the amount of bleeding that they have.
Yeah, that makes a lot of sense. Thank you for that comment. So when it comes to dosing oral progesterone, there's a lot of debate here, and some doctors are big into transdermal progesterone, some are big into oral progesterone. The most common dose that we see is 50 to 300 milligrams of oral progesterone a night. I like oral progesterone because it is metabolized allopregnanolone, which will help women to sleep. So I like it that way. And what's your opinion, Dr. Bahnmiller, on transdermal oral?
I prefer oral just because it's simple, it's easy to dose, and then I can kind of gauge as far as, okay, is it helping sleep, and how's other symptoms. I just find it much simpler, and women tend to prefer that one.
Yeah, me too. I like it. And it helps them sleep.
Simple.
Yeah. Let's see.
Yeah, the sleep part's great because, especially when you're going through menopause, but I mean, just a lot of us have a hard time sleeping, and I like it for just kind of a natural, nice way to help you sleep.
Yeah, one thing to remember is that commercially available progesterone, the Prometrium is the brand name, does have peanut oil in it, and some people are allergic to peanut oil. So I like the SR progesterone. It's sustained release, and it slowly releases throughout the night. That's how we normally compound it at our pharmacy. Okay, so let's move on to testosterone. This is a big one for Dr. Bahnmiller with his how he helps women with sexual health. Benefits of testosterone. Women have testosterone too. Traditionally, it's thought that only men have testosterone, but women have it also, just less than men. Testosterone is very important for many things. I think it's the best hormone there is. Testosterone is an anabolic hormone. Men get osteoporosis also. It's not from lack of estrogen or progesterone. It's from lack of testosterone. So maintains lean body mass, strength, stamina, improves mood, great for depression. Cardiovascular benefits, it lowers total cholesterol, skin health. There are so many benefits of testosterone. So, Dr. Bahnmiller, quickly, you want to talk about testosterone in women really quick?
Well, one of the things I get from women a lot is they go through menopause and, they get put on estrogen, but they don't get that. It's not balanced with testosterone. And their biggest complaint is they try to lose weight and they just can't lose weight. And then they also feel like they get like a trunk obesity, and they're doing everything they can, eating right, exercising right, and then on top of that, they don't have the zeal or the energy. And a lot of it just comes down to looking at their testosterone and balancing that, because estrogen and testosterone, just like progesterone, they work together. It's not like you can take one out and say, oh, this will fix everything. I mean, the body has them for a reason. And when you look at like all the benefits you mentioned there, but really when somebody comes in and they're like, oh, I'm sleeping better, I feel like I get a good night's sleep, but I just don't have the energy. I just don't feel like I can go for a run like I used to. It's usually their testosterone. And the women don't appreciate that fact. Yeah, we always think of like libido, but there's so much more to it. I mean, that's a huge important factor. But really, when you listen to them, most of them will say, I just don't have that strength I used to.
That's right. All right, let's go on to the next slide. Let's talk a little bit about dosing. This is pretty simple. I'm a big believer in vaginal testosterone also, because it's absorbed systemically. You'll get systemic effects, but atrophic vaginitis, testosterone is great for that. It's also great to strengthen bladder muscles. I love vaginal testosterone. There are other ways to get it. You can get it in pellets, which is, an office procedure that a doctor does. There's some benefits and advantages of that. And oral testosterone is not absorbed very well. Injections, injections are injections. So, what are your comments about testosterone and dosing?
If I can get a woman to do it vaginally, I think that's the ultimate, because the absorption I think it gives you great levels. The other thing is that when you look at the vulva, a lot of people are like, oh, you have vaginal dryness, we're going to give you estrogen. The part that's not appreciated is the vestibule, which is the area right around the vaginal opening, and a lot of women have painful intercourse. That area is highly dependent on testosterone. As it's dependent on estrogen, but it really needs testosterone. So when you have somebody apply it and they apply it between the labia around the opening, that's going to give them the best effect for decreasing painful intercourse, helping with symptoms of vaginal dryness and discomfort, and helping them get a good serum level. I can't stress enough as far as using testosterone there, because if you use it alone, you're missing most of the picture.
I agree. DHA, we're not going to hit on this because I want to get to some case studies, but DHA is important. It's made more in the adrenal glands. Can dose it orally every morning. DHA is important for sure. And it does convert to testosterone somewhat in higher doses. Melatonin, we're not going to hit on very much. Thyroid, I like to talk about thyroid because when I think of thyroid, when I think of low testosterone symptoms, low thyroid symptoms mimic testosterone. So you really have to check both. And when you look at low thyroid symptoms, depression, weight gain, decreased libido, those are all symptoms of low testosterone. Dr. Bahnmiller, you have any comments on thyroid?
I think thyroid's impaired. It's really important for us to check that. And, otherwise we'll be struggling to figure out, what else is going on. But I think what you got there covers it.
Yeah. All right, let's go. And we're going to hit thyroid just really quick. So there are two forms of thyroid, T4 and T3. T4 is levothyroxine. T3 is liothyronine. They're both simple hormones. They're iodine along with tyrosine. T4 has 4 iodines. T3 has 3 iodines. T3 is actually the active form of thyroid. So the most commonly prescribed thyroid is T4, levothyroxine, also brand name of Synthroid. It has to actually be converted into T3, liothyronine. in order to be active. That's the more active form of thyroid. Many patients don't do that very well. So it's important to recognize that a woman's labs might look normal as far as TSH, and she's on thyroid, she's on levothyroxine, but if she's not feeling better, it's important to know what their T3 levels are. Very, very important. So go ahead and let's go to the next slide. And one of the reasons for this poor thyroid function is just decrease of conversion of T4 to T3. That can be due to lack of selenium. That can be due to increased binding, i.e. the thyroid is not free in the body to work at the receptor site. That can be caused by birth control pills. That can be caused by too much estrogen. So it's important to know those things to get optimal thyroid function. Let's go to the next slide. Factors that decrease conversion of T4 to T3, lack of iodine, lack of selenium. What else? Oh yeah, prednisone. Forgot about that one. Can cause that. So thyroid is very, very important. Go to the next slide. This is kind of obvious as we age, our hormones just in general, including thyroid, function less. So I think that's our last line. I think what's important when it comes to testing thyroid is that we don't just do TSH, which is the gold standard. TSH is actually a pituitary hormone. It's not a thyroid hormone. So I believe it's important to get your free T3 and free T4 levels, especially free T3, because it is the active form of thyroid. Dr. Bahnmiller, you have a comment on thyroid?
I totally agree. I think so many times we just check TSH, but I always check the free hormones just because I want to see what the thyroid's doing and how the body's converting it.
Yeah. All right. Let's go on. I talked about synthroid, armor thyroid. Realize when we go back to natural, when a woman comes and says, "Well, I want natural thyroid only," armor thyroid is natural. It is ground up pig's thyroid, literally. I'm not saying that it's necessarily bad. It is a combination of T4 and T3. So some women do okay on it. Just realize that some women, it might not work for them, because they produce antibodies to it, because it is an animal product, and you can't change that ratio of T4 to T3. It's fixed, and it's not sustained release, and T3 is short acting. So many times they need it like a sustained release thyroid, like a sustained release T3, which is something that a compounding pharmacy can make up. Go ahead and go. So dosing of the T4 is 50 to 150, T3 10 to 30. You can combine those to make them easier to dose. Remember, T3 has a short half-life, so that's why an SR combination is probably best. You have any comments, Dr. Bahnmiller?
No.
Okay, perfect. I just mentioned vitamin D because it's so important. Vitamin D is a hormone in itself. It has a cholesterol backbone like many of the sex hormones, and it does more. I've had women that their hormones are balanced and they're doing great, or they're doing good, but they're not doing great. And then they start taking vitamin D and they do much better. So I just think about vitamin D and think about optimal dosing of vitamin D. Most women are low, especially in northern latitudes, and most women need 4 to 10,000 units a day. Make sure it's an optimal range. Let's go. So testing of hormones, I'll let Dr. Bahnmiller definitely comment on this slide, but I believe estradiol, progesterone, testosterone, DHEA, and at least a morning cortisol, maybe 4 times throughout the day, which is not always convenient, but it can be done with saliva, and free T4, free T3, TSH, vitamin D. Dr. Bahnmiller, this is where your expertise comes in.
The only thing I'd probably add to that is when you do the estrogen, I always do a sex hormone binding globulin, because I like to see I calculate out the free testosterone. You can get a free testosterone from the lab, but that's a calibrated one. The one I like to use is actually you can go on your phone, and I think it's called free T4. Basically, so we take the estrogen, testosterone, sex hormone binding globulin, your total albumin, and we get the free testosterone, which is your active form. And then sometimes I'll do a dihydrotestosterone. If those look normal, but she's still having symptoms of low testosterone, I'll just see, is there something blocking? A lot of times women are on things like Accutane. They're on things that actually block the conversion to their active form of testosterone. So it's important to know those. We usually treat on total testosterone unless they're symptomatic and those other ones are low.
Yeah, that's right. All right. Thank you for that. So I think we're about ready to go into some case studies. So 42-year-old female with Cyclo migraines. Remember when I talked about cycles? What do you think of when you think of cycles? You think of progesterone. So, you know, history of a car accident, and she's taking hydrocodone, gabapentin. These are very common. Fluoxetine for depression. Remember, anytime there's cycling issues, check their hormones. Definitely check their hormones. Let's go to the next slide. And if you look, I think just on that was just, you know, if there's a cycling issue, check their hormones, and hormones can fix many of those symptoms. So if you look at that depression, you know, if you don't have balanced hormones, you can have depression, and we're going to talk about that in this case too. So 49-year-old, go ahead.
Mentioned, you know, you brought up briefly before about testosterone and the effects of on diminishing. If your testosterone is low, a lot of times that'll diminish, increase your risk as far as depression, and especially with how our society is very stressed, it's straining our adrenals. Then we get less DHEA, we're producing less testosterone. So yeah, we see it much more in men that it helps, but also testosterone helps women for depression too.
Absolutely. Absolutely. Thank you for that comment. So here's a 49-year-old, recent diagnosis of fibromyalgia. I'm sure Dr. Bahnmiller has seen patients like this. Cycles become more irregular. Think progesterone. Gained 15 pounds over the last year. Hair is thinning, decreased libido, decreased energy, depression. Recently started citalopram, you know, for depression. Recent diagnosis of high cholesterol. Started atorvastatin. Feeling aches and pains all over. Started taking hydrocodone, gabapentin. So we check our hormones. Patient is currently on levothyroxine, 0.1 milligram. I didn't put units in here for the labs, but they're just all relative numbers. So just think about that. So her testosterone level, 15 to 70 is normal for total testosterone. Her level comes back 17. So she's on the low end of normal. Her TSH, 2 to 5. That's a huge range. You know, she's at 2.9. So, you know, her TSH is normal, but her free T4 is normal because she's on levothyroxine. Look at her free T3. It's on the low end of normal. So let's go to the next slide. And her free testosterone, but look at her free testosterone. This is very common. Her free testosterone is 0.1. So her free testosterone is definitely low. So her testosterone is not working at the receptor site. That's why it's important, like Dr. Bahnmiller was saying, to get free testosterone versus total testosterone. And you can definitely, probably the more precise mechanism is what he was talking about, checking sex hormone binding globulin. You know, I think it's just important to know what's going on with the free testosterone. So she's got low thyroid, some low testosterone symptoms. They mimic each other. Free T3 is very important. So here's a treatment. We put on testosterone, 2 milligram vaginally. We put on add some T3 SR to her regimen, along with her levothyroxine. Because remember, T4 is fine, TSH is fine. Then we recheck those numbers in 8 weeks. Think about DHEA. Definitely think about progesterone in this patient. And I'm honestly, I'm sure if this was a patient, Dr. Bahnmiller's, I'm speaking for him, but I'm sure this patient would probably be on progesterone. You know, because most women this age, when they need those hormones, will probably need progesterone also. Can help them sleep, you know, normalize their cortisol levels, maybe help for her night sweats. Go ahead and go to the next slide. So if you look at what happened, her testosterone came up to 5.1, which is a little bit high. Her free T3 is up to 4.6, which is a little bit high. Free T4 didn't change. TSH drops. This is pretty common. But let's not get too freaked out. You know, testosterone's high, but she doesn't have any symptoms of acne or oily skin. So let's not, you know, overreact. You know, when did we do the lab test? When did she take her last dose? Those are all important factors to think about when we're checking people's hormones. You know, along with the thyroid too. So her thyroid might be a little bit high. Her T3 is a little bit high, but you know, if she just took it that morning and she had a lab test 1 hour later, you know, it's going to be at its peak. You know, later on in the afternoon, their thyroid is going to be lower. Same with testosterone. So let's think about that. But look at these things that we did. Feels much better. Increased libido. Cholesterol's lower. Pain levels are decreased. Losing weight. More energy. You know, can we stop her atorvastatin? And atorvastatin can definitely cause pain and fatigue in the muscles. Can we stop her citalopram? It can cause decreased libido. And, if her hormones are out of balance and we help her depression with that, she doesn't need a drug anymore. So, we're treating problems, we're fixing problems, we're not treating symptoms. It's important to know that labs are a tool to go along with symptoms and history, that, they're not black and white. There's a lot going on in this slide, Dr. Bahnmiller. What are your comments?
I think one of the things that you're talking about, trying to figure out how do we decrease her antidepressant stuff. One of the things to always keep in mind too is going to be your B vitamins, especially your methylfolate and stuff.
That's
right. That'll help diminish the amount you need for antidepressants, or may even minimize or eliminate the need for it.
That's right. That's right.
Always keep your B vitamins in mind.
That's right. And like you say, it's special B vitamins, so L-methylfolate and methylcobalamin. That's good. Okay, let's move to the next. Another
interesting thing you brought up about having high testosterone and, she doesn't have acne. I think a lot of times too, it's like a shotgun approach. You go to the dermatologist with acne and they put you on like Accutane or aromatase inhibitor to decrease their testosterone. Well, you just wiped out their testosterone, but did you balance anything else? I mean, one of the things that a lot of times with those women that have acne, try a little progesterone. It may be that you just need to balance that in that later stages of their cycle, so that way, it kind of complements the testosterone they have. I mean, why is it always that testosterone that women have is bad? It's like,
that's right.
They need testosterone too.
That's right. Thanks for that comment. Okay, here's one, and we talked about it a little bit. This is another very common, 55-year-old UTIs requiring ER visits. History of urinary incontinence, vaginal dryness causing painful intercourse, marital issues. She had a total hysterectomy. Of course, we kind of defined what that really meant. Dr. Bahnmiller did. She heard it was dangerous to take HRT over 5 years, so she stopped it. And next thing you know, she is taking nitrofurantoin daily for UTI prevention and oxybutylene for urinary incontinence. And these things are causing some side effects. So unfortunately, the family doctor sent her to a urology specialist, and he prescribed estriol vaginal cream, which is, or he prescribed estradiol vaginal cream, but it wasn't covered. It was expensive. So then the urologist prescribed estriol vaginal cream, which was much more affordable, and she could afford that. She started the estriol vaginal cream. 8 weeks later, vaginal dryness cleared up. UTIs cleared up in 4 weeks. She can stop the nitrofurantoin. 6 months later, follow up, urinary incontinence resolved, stop oxybutylene. And the common question is how long should she stay on the estriol vaginal cream? Well, I tell women they're not going to magically start producing their own estriol anytime soon. So if they want those symptoms to stay away, they will stay on it for the rest of their life. So cycles became more irregular. Remember, think progesterone. Look at the medication list she's on: sertraline, lovastatin, zolpidem, venlafaxine for hot flashes, and generic Fosamax for bone density. Started on some progesterone, some estrogen, some testosterone, some thyroid. And, a lot of those symptoms, those symptoms can go away. So her cholesterol, depression, hot flashes, and hormones can help with so many of those symptoms that she had, get them off a lot of medications, and of course have a lot of other benefits too. So possibly of eliminating 5 different medications and improving the quality of life. So I think that concludes our presentation. Thank you for listening in. Thank you, Dr. Bahnmiller, for being on today and adding your expertise and your wisdom.